Thank you so much. And it's just a friend of the house, a friend of Ophthalmic University, Dr. John Kanellopoulos in Greece. Thank you so much for being here again, Dr. What a honor to have you.
Thank you, Andres. It's really a pleasure to be here and to have a fruitful conversation with these excellent colleagues. You're quite the person to connect the universe. And I think I'm speaking of all of us. This is a period where we have been deprived of being together in meetings. So, this is a fun time for us. So thank you for putting us together.
Thank you so much for being here. It's our honor. Let's have fun. This is a friend meeting, so let's enjoy it. Dr. John Kanellopoulos, whenever you want,
okay,
we are ready for your masterclass.
Okay, well, I wouldn't call it that. It's let me see if I'm sharing my screen. Are you? Is my presentation on?
Not yet.
All right. Let me go back to share. Okay, there we go. Now it should be on.
Yes, perfect.
All right. So I'll be speaking on the lessons that I have been taught by many of the colleagues that we've been working with together through the years on customization of cornea ablations. And this is a lot of material. I'm going to try and go through it in a very succinct way, and of course create some nucleus for discussion and further presentations. Whenever we speak of refractive surgery,
Dr. John,
always.
I'm sorry. Can you put the presentation mode?
Okay.
If you go.
Absolutely.
Yeah.
It's just covered by the Zoom. There we go.
Yes. Perfect. Whoa. No.
No. Okay. Here we go.
Oh, that one. That one.
Okay.
Perfect. Okay.
There we go. Is that better?
There's a button that says swap displays on your upper left, because we can see your presentation mode, but not your actual presentation. So upper left, you have the swap displays. That one.
Fantastic. Is it better?
There you go.
Yeah. Excellent.
Okay. Thank you. Fantastic. Thanks so much. All right, so we'll be talking about customization of laser ablations, and I was saying that this talk and this discussion for the average refractive surgeon does require in-depth knowledge of cornea imaging principles, and I would point our viewers to a YouTube narrated presentation that goes step by step through all the important points of current refractive cornea imaging principles, which we're going to be using in our talk interchangeably. And I was asked to speak on topography-guided ablations and Contura laser applications, which is the trademark for Alcon, which has been the spearheading manufacturer of topography-guided treatments globally. The concept was initially born in Europe many years ago as a ways to use the laser for therapeutic applications. And we're seeing some of them. This is a presentation from 2004 at the American Academy. So yes, I'm old enough to have been presented back then. And it came to fruition in several papers where we utilized what was then the initial steps of topography-guided treatments to use it in therapeutic ways. On the left, we're seeing an enlargement of an optical zone. Patients from 2 decades ago that had broad beam lasers that had small optical zones in the 90s. It's a well-centered ablation, as we can see, but gives a lot of halos and problems at night. So we're able to enlarge that optical zone. We're able to treat on the bottom middle, we're seeing a cornea irregularity that came through a cornea infection. And usually scarring creates the significant inferior flattening. It's as if we're looking at keratoconich eye upside down. So the cornea here is steeper on the top, flatter on the bottom, because that's where the scar took place. And we see the picture next to it. And this is the, I'm putting my arrow on at the middle bottom picture, how the topography-guided technology was able to magically shift this. And I want to remind our viewers that back then, this is in 2003, if the patient was intolerant to contact lenses, this pathology meant cornea transplant. So we can all appreciate how back then this was a really groundbreaking innovation on the therapeutic front. And of course, we took this, and the rest of the pictures are treating irregular eyes such as a keratoconus and trying therapeutically to improve the visual quality. And that's where the Athens protocol took birth. And we were able to combine cross-linking and a topography-guided treatment and have a keratoconic eye. Now it's as if we're looking at the previous example upside down, where we have inferior steepening and combine it with cross-linking and have a remarkably normalized cornea in the middle. And we can all appreciate how the synergy between the topography-guided treatment and the CXL gives flattening of about 10 diopters. Either one alone gives about 1 to 2 diopters. But it was not until the FDA study that Alcon spearheaded back in 2013, where now the topography-guided platform with the Wavelight Alcon laser was used to treat naive, myopic, virgin, if I may use the term, eyes, that we learned that this technology gave the best refractive data than any other technology had gone through the FDA, and still has. There is no technology that has gone through the FDA with this type of data, with a large percentage of patients gaining lines of vision. So then we went back and we start thinking, why is it that the topography-guided treatment improves visual outcomes so much in comparison to what we have been previously used to with all platforms? And all platforms have reached the point to give good refractive data. Today's lasers are all very good at giving what we call a 20 happy patient, a refractive surgery patient that wants not to wear glasses. Here we're talking on how not just to get rid of glasses and contact lenses, but improve the eye's visual ability. So by breaking down the data, and this is very technical, we're seeing here on the Contura platform, the refraction of this patient, which only has half a diopter of astigmatism, where the measured refraction by the device points out to 1 diopter of astigmatism on a different axis. So the axis of the refraction is a red diametric line on our left image, where we can clearly see that the cornea topography shows that it's a, with the rule, almost 90-degree topographic astigmatism in this patient. And this is puzzling. Why is it that the patient consistently gives us a different refraction? And we have learned to treat clinical refractions, and that's still the gold standard for most surgeons throughout the world. So here we're compelled to look at these data and see that the topography-guided treatment will normalize this cornea. And the key thing here is an angle kappa. This is a regular astigmatism, but with the angle kappa, and you can see I've circled it here on the left image, it's quite significant on the x-axis and on the y-axis. Any deviation of on the angle kappa of more than 100 microns is significant. Creates coma for the patient, which we can see on the picture on the right. And this is what the topography-guided software is trying to normalize if we set the treatment to 0 sphere and 0 astigmatism. So this is a coma treating ablation that is added in the Contura vision ablation of this eye. And this will normalize the cornea optics to the visual axis of the patient, meaning the cornea vertex. And this is the key element of why, if you want, the undercover magic in Contura giving us the supervision results. More detail on how this works. And we had further suggested that besides using Contura, we can tweak a little bit the astigmatism measured by the Contura device and move towards halfway or full way to the Contura defined amount of cylinder and axis. And we call that TMR. So going into plain English, this is a patient that is treated one eye wavefront optimized and one eye Contura. And both eyes are 20/20. So why are we having this discussion? Both eyes, the patient is happy. But if we look at the postoperative cornea topography, we can all appreciate that the left eye, which is on our right, top are the sine fluke images, the pentacam images, and bottom, the reflection placido images. The left eye has a much better topographic normalization because topography guided was used with TMR, where the right eye still has topographic astigmatism. And sometime in the future, the patient may request that astigmatism, and we may think that, well, the treatment has regressed. So this is the reason why our Contura treatments are superior. We're fortunate to have been assigned an investigator-initiated trial by Alcon to study a 50% TMR versus 100% TMR. And I know the Versitis software, which is also a great innovation in using Contura, is doing this automatically. But here we studied going 50% on the difference between the refractive amount of cylinder and the Contura defined amount of cylinder and the difference in axis, or full Contura suggested axis and amount of cylinder. And what we found in this interesting study, and this is reviewed under publication, is that even if we go 50% towards the Contura suggested amount on axis of cylinder, we have a marked improvement in lines of vision gained. So even if one is timid to go with the topography measured amount and axis of cylinder and wants to go 50%, half the way of that difference, it's still worth a while because the data are quite impressive. And we heard the question before, okay, the new kid on the block is also SMILE. And SMILE came out strong, advertised as the procedure that is different from LASIK, may offer more biomechanical stability, may offer better visual outcomes. And we had the opportunity to study side by side, and still to my knowledge, this is the keynote study, one eye randomized to have Contura LASIK and the other eye to have SMILE. This contralateral eye made the study extremely powerful. And we showed that the SMILE eyes did well, did similar to a wavefront optimized platform, but the Contura eyes did superior. Not that they only did they reach 20/20, but they went a very large percentage, as we can see here, to 2012 and 2015. So the superiority of the Contura eyes were probably based in the magic secret that we talked about before, that addresses cornea astigmatism and cornea coma and lines up the cornea optics to the vertex of the eye. And plus the fact that the laser with a platform such as the Alcon platform has second rotation adjustment, which for astigmatism is very crucial. SMILE up to the point is not able to cycle rotate and adjust for axis of astigmatism and cycle rotation, and thus it's expected to have inferior results when we're correcting cylinder. Now, the other promise of SMILE was that it will not give dry eyes anymore because we're working under the surface, and we studied this in this very valuable study for us, and we showed that the two procedures are more similar. These are cornea epithelial maps all the way 2 years out, and we've summed the epithelial maps in what you're seeing here at 1 month, 3 months, 6 months, a year, and 2 years. And you can see that although the LASIK eye is a little drier the first 3 months, at the end of the day, the two procedures are more similar than different. So there is dry eye with SMILE, so that is not a clear advantage. We also showed that as far as the accuracy of tissue removed between the LASIK eyes and the SMILE eyes, that LASIK, of course, is still more accurate than SMILE, so less refractive surprises in high myopes, which for SMILE means -5 to -8, maybe -10 if you're outside the US. And last, this is another study from that same study, a spin-off project, and I'm closing with this. We looked at the topography change with a pentacam before and after the procedure. And you're seeing here an example on the right. So we were able to take this topography image from the pentacam. So this is a tomography image, the difference map at a week. And we chose the sagittal, the tangential map at a week because they had the sharpest borders of the ablation effect. So we were able, since the pentacam by theory is centered on the vertex of the eye, we assumed that this image is centered on the visual axis of the eye. So we were able to compare the LASIK with Contura eyes to the small eyes. And these are the compelling data. The LASIK deviation from the center of this image, which theoretically is the cornea vertex, was 130 microns, where the small eyes were 313 microns. And it really underlines the power that our excimer lasers have today, and specifically the EX500. So not only with the Contura, we're able to treat cornea coma, we're able to adjust cyclorotation, but we're able to aim more precisely at the time of the procedure. And this is really an eye-opener for us. And of course, all this work is confirmed. I know it's not our subject today, but I'm going to brush a little bit with the technology and development, the ray tracing, which shows us that when we leave the artificial intelligence to study all the higher aberrations and the objective data and lining up the optical parts of the eye, we're getting better visual acuities. And there is an ongoing US study, international study with ray tracing. I will not go into that into depth, but I wanted to mention that the ray tracing, the Innovize data really underlined what I spoke about before, our outstanding Contura data. So in summary, we have found, among with other investigators through the years, and hundreds of colleagues are using this technology as their everyday refractive tool, that the Contura eyes not only give us the promise of a 20 happy patient, but really explore the venue of improving the optics of the eye of a patient, and they're able to unlock gain of vision in patients. And nothing is more fruitful than this. You can imagine a patient after a LASIK procedure seeing better, much better than they saw with contact lenses before. We're talking about a great practice booster here. But you know, at the end of the day, we're physicians, and this is outstanding to be able to give the gift of improved eyesight to patients. Of course, this is something that requires good understanding of cornea imaging and all the logistics involved in the Contura treatment. And I think that these technologies are able to help us not just explore patients without glasses and contact lenses, but also patients that can function for the rest of their lives with improved visual outcomes. And I think that's a very valuable lesson for all of us. That's all I had for you today. I think we brushed a little bit through some key elements, and I really want to thank you for hosting me today. It's really a pleasure and an honor.
Thank you so much, John. Outstanding presentation as usual. The first concept that came to my mind is this concept about go beyond 2020, right? And I think that is one of the most important things, and it's incredible when you show evidence about it, right? Guys, Anshal, Nitin, Dr. Rosman, your thoughts, your opinion about this incredible presentation. What is your opinion about
Dr. Rosman? I would just like to say, you know, this has been coming up repeatedly, that you have to have a good scan in a good topography. So, you know, a lot of people ask that, how do you know, seeing a topography report? So I would ask this to you, Dr. Anchal and John, that, you know, how do we know that we have a good topography? Who is a good technician to take a good topography? You know, put some light on that.
Dr. John, that is one of the keys, right?
It's a great question. It's a great question, and it was mentioned by Dr. Gupta previously that you have to, if there is a significant difference between your manifest cylinder and your Contura suggested cylinder, you have to confirm with a total cornea device such as the Pentacam that there's no posterior curvature difference that may cause this. So you have to confirm that the total cornea power is indeed different than the refractive power. The other great pro is you have to have consistent topographies. We have uploaded on our YouTube channel several tricks on how to use your Vario device in making sure that the patient's head is balanced, the two eyes are balanced. And this is something you have to teach your optometrists and technicians, that the head has to be in such position that swinging left eye to right eye, you don't have to adjust up and down. Also, I personally use cornea epithelial maps as the crossroads of whether I'm going to base a treatment on cornea imaging, because if the epithelial maps are not naive, and the cornea epithelial maps are very strict in what's naive and what's not naive. They're not very specific on what the cause of the epithelial irregularity is, but if the epithelium, and we use the OptiView, I think it's the most popular device, but there's other devices coming out that in this device, the epithelial map has to be as green as possible and as homogeneous as possible. So if there's irregularity in the epithelial maps, then of course one has to consider that the topographic data are not very accurate, and addressing the reason for the epithelial deviation probably precedes a laser treatment, or one can decide into a more basic treatment. So I would say, in plain terms, if you have the ability of epithelial imaging, that's a great way to use it as a validation method for the stability of the object that you're trying to image. If not, you can go into the studying the Placido rings. I'm old enough to have seen the device by Dr. Placido, and how the computerized devices use those reflection rings. Analyzing those rings and seeing how clear and reflective they are gives you an idea of how normal the cornea surface is. So that's another way to assess whether your topographies are reliable.
Usual. Thank you. Look, we have a lot of questions. One of them is for Dr. John. Dr. Ho Shi Shan asked you, Professor Kanellopoulos, how many cases of 100% of your LASIK procedures are done with Contura? Do you have that number?
For us, if I speak of my personal practice, if I both in Athens and in New York City, I do Contura about 85% of cases. And the only reason to exclude my LASIK procedures from Contura is the reasons we discussed before. Assessment that the epithelial surface is unstable. In my hands, it's usually patients who abuse contact lens use. I mean, most of the epithelial problems that we see that may interfere with the clarity and the reproducibility of the imaging is usually contact lens related. But again, those are the patients that are the most motivated because they already have problems with contact lenses. And, I agree with what was discussed by our panelists before, that treating the external disease will help eventually, number one, possibly paving the road for a Contura treatment. Number two, getting a more accurate measurement and a smoother postoperative recovery.
There's a clear algorithm. Because of that, I have a quick question for Dr. Kanellopoulos. In your practice, Dr. Kanellopoulos, how that you're very well trained and you do 85% of your cases with Contura, how much time do you add to a procedure? I think pretty small, right?
It does add time as far as the diagnostics. And thanks for the question. Please call me John, and congrats on your amazing representation with that 360. I'd love to, once we're done with this, sit down with you and you can teach me how to do that. I'd love to use that technology in educating patients. But assessing patients with a Contura platform takes more time. There's no question about it. And this is, in my opinion, the biggest bottlenecking in applying it in your practice. But I think that we heard it before in the very nice presentation, to benefit your patients, refractive surgery is a tool on its own, but you can view it as a single stop for a young, healthy patient that you can flag some other issues and some other problems. So in my mind, being a cornea external disease specialist, it goes without question that I do not only want to get rid of the glasses for a patient, but also study the optics, see why is there a difference between the refractive cylinder and the objectively assessed cylinder by topography, the ocular surface, the reasons that someone wants to have surgery. So for us, it's a given. So any case, even the cases that I'll do waveform optimized, do have ready data for Contura. Even the cases we're doing for the Innovi studies currently do have all the data for Contura, and we run both platforms simultaneously. So it does take more time. In VR, it takes maybe 1 or 2 minutes to look at both platforms and decide and look at the data. But I think that it's driving a car with many more instruments rather than driving a car with just one instrument. It gives you a better understanding of what you're doing, where you're at, et cetera, et cetera.
Excellent. Excellent. For me, it's very simple. It's very straightforward. Everything is about precision, about safety, and about offering our patients something very personalized. And I think it's a value proposition also for the surgeon, right? To personalize the treatment and to go beyond 2020.
Absolutely, absolutely. Thank you so much, Ivo. Robbie, we're finishing. Thank you for your valuable support. May, thank you so much, guys. It could be impossible without you guys.
Thank you so much,
Thank you
Andres.
for having us.
Yeah, I want to thank the entire Ophthalmo University team for this great program, the panelists, and obviously the guest speakers as well. Fantastic program. Looking forward to the next one next week.
Next week, we're gonna talk about complication management. So it's gonna be very, very interesting. We're gonna have Demi Gatinel, Professor Bai Ji, Shen Shewo, and Dr. Rick Wolf. Che, Brian, Thomas, thank you so much. Hi, Che, your first time here with us. How was it?
All ours. Amazing, amazing. I actually sent a message to Jason thanking him for laying it out as simple as that.
Absolutely. Thank you, Shay, May, Ishtiaki. And before we say goodbye, thank you, Professor Kanellopoulos, because your job is so amazing. We learn not just from your presentation today. You have so many papers, and we have been learning from so many years from you. Thank you so much for that incredible work.
Thanks for having me. Really enjoyed it.
Thank you, guys.
Take care.
See you next week.